Hello, this is a highly simplified video about infections. So we'll talk about some antibacterials, some viruses, some protozoal diseases, and some antifungal treatments. So many bacteria live in the human gut, on the nose without causing any problems, but some of them cause very serious disease in the humans. Viruses are more dangerous in the suppressed patients, for example, patients with HIV and so on. So in the immunocompetent patients, they normally cause um, self-limiting infections like upper respiratory tract infections. Fungal diseases are the same, so basically they cause opportunistic infections in the immunosuppressed, like aspergillosis in patients with HIV or COPD, or in patients who have chronic tuberculosis in poor countries. Um, Also, some protozoal treatments like malaria. So, if you go back at the structure of bacteria, protozoal, fungal, so basically this all revision from any students from health science programs. So I won't go through them, as you can easily find from textbooks. And if you look at the classification of bacteria, this is also revision. So it's good idea to have some. It's good to have some idea of the classification of bacteria because of the different antibacterials used, so you could have an idea which antibacterial might be suitable for any um, specific bacteria. So one of them is the gram staining, um, the gram positive and the gram negative, the cocci, the rods, so staphylococcus aureus, the MRSA, streptococcus, they also have peptidoglycan bacter lactamase producing bacteria. Also, resistance, very important topic in infections. So it's a good idea to memorize basically the most important gram positive and gram negative bacteria. For example, in exam situation, you could be asked if bacteria is gram positive and gram negative. So, for example, Neisseria meningitis, E. coli, H. influenza, Vibrio cholera, Pseudomonas aeruginosa, Salmonella, Shigella, which cause food poisoning. Also, resistance is high in gram negative bacteria because remember they have two plasma membranes and very thin peptidoglycan. So basically, um, that you need a broad spectrum antibiotic to treat gram-negative bacteria. Also, some important anaerobes include the Helicobacter pylori and the C. diff infections, Clostridium difficile, tetanus, botulism, um, and the antibacterial of choice in all anaerobes are metronidazole and vancomycin. So will not be talking about metronidazole any longer. So the interesting point is to remember that if you see any anaerobe, we use metronidazole, and it's the chemistry of metronidazole that makes it interesting because it's only um, reduced when the metronidazole is taken up by anaerobe. So that as far as we'll go with metronidazole in this video. Some bacteria include the myobacterium, like the bacteria that causes tuberculosis and chlamydia. So there are many classifications you could read. There's plenty of textbooks which cover in more detail. And this a quick summary of which bacteria infects which part of the body. I found this on Wikipedia, so you could stop and basically have a look or read on Wikipedia if you find it useful. The most the usefulness of this video is basically you could look at different sides of the body and think of which antibacterials might be useful to treat. And then if you look at the targets of antibacterials, basically this is very important to remember for beta-lactams like penicillins, cephalosporins, the monobactams, basically all beta-lactams and vancomycin target the cell wall. If you remember the peptidoglycan, the cell membrane, especially for gram-negative bacteria, colistin, metabolic, this is basically the folic acid pathway in trimethoprim and sulfonamides, the DNA and RNA, quinolone and rifampicin, and the protein synthesis. It's the tetracyclines, aminoglycosides, macrolides, chloramphenicol, and clindamycin. And remember, tetracycline and aminoglycosides target the 30S subunit and the other three target the 50S subunit if you find that useful. Um, so when it comes to antibacterials in pregnancy, the safest where people have used for so long without any problems are the penicillins and the macrolides. Nitrofurantoin is used, clindamycin is used, trimethoprim should be avoided in patients who use folic acid inhibitors like trimethoprim or sulfamethoxazole, or patients with immunocompromise because it blocks the synthesis of DNA. Antibacterials to avoid in pregnancy include aminoglycosides, tetracyclines, quinolones because of the deposition of tetracyclines in the developing babies. Hypersensitivity, all antibacterials with special importance, penicillins and other beta-lactams, sulfonamides, trimethoprim. So basically, for all antibacterials, but be aware of these. GI symptoms, all antibacterials, but more importantly, the pseudomembranous colitis, where C. diff colonization of the colon happens, and there's severe diarrhea. So most important is the clindamycin and broad spectrum antibiotics like quinolones, amoxicillin, um, ampicillin, ciprofloxacin, and amoxiclav. So basically, broad spectrum antibiotics. Renal and hepatic problems. So basically, amino. So it's color coded aminoglycoside. Tetracycline is both hepatic and renal. So penicillins and cephalosporins, renal problems, especially penicillins with methotrexate, flucloxacillin, hepatic cholestasis, sulfonamides, ethambutol, isoniazid, hepatotoxicity, rifampicin is both renal and hepatic. So you need to be aware of these side effects. And if we look at a specific side effect, so basically aminoglycoside ototoxicity like gentamicin. So and they are mostly dose related. So and the aminoglycoside is the other interesting feature is they are all parenteral. You can't take it oral. And also nephrotoxicity as well. So they also narrow therapeutic drugs. So you need to monitor the concentration of aminoglycosides. Tetracyclines are more associated with photosensitivity and tooth discoloration, as we said. They are contraindicated in children under 12 and in the pregnant and the breastfeeding. The quinolone, they cause arthropathy, or basically rupture of the tendons. So basically, it's very important to be aware of. Also, QT interval prolongation, especially with I think moxifloxacin and oxifloxacin, and patients with epilepsy, especially children and adolescents. Ethambutol basically is eye problems, visual acuity, blurring of vision, especially children who cannot tolerate symptoms of eye deterioration. Chloramphenicol is enzyme inhibitor, so remember, or also hypersensitivity. Um, I isoniazid with neuropathy, so again, think of a patient with diabetes who take neuropathy or alcoholism. So pyridoxine is given to patients who have high risk factors for neuropathy. Myasthenia gravis, for basically, you need to avoid patients. Antibacterials like aminoglycosides, tetracyclines, cephalosporins, uh, and so on. Um, we also saw the aminoglycosides, ampicillin, ciprofloxacin. Macrolides, remember, are enzyme inhibitors like clarithromycin is very potent enzyme inhibitor. So remember, um, interaction with warfarin, statins, other enzyme inhibitors, and induces. It also prolongs QT interval. All macrolides prolong the QT interval. So if you give with other medicines that prolong with QT interval prolongation, like some antifungals, antipsychotics, fluoxetine, and citalopram. Um, also, on the 554 antagonist like on the cetron. So remember your QT interval drugs, so that you do not give put them together. Also anti-malarials as well. Rifampicin is a potent enzyme inducer, so and also it discovers physiological fluids like urine, eye. So remember patients who wear contact lenses, and also warn patients the discoloration of their urine. The lamanate also causes QT interval prolongation. So if you go on, I think these are some infections where you need to know what the symptoms are, the how to treat them, monitoring, and also community-acquired pneumonia, hospital-acquired pneumonia, also tuberculosis, very important. The continuation phase, the patient who are supervised, patients who take it independently, how to monitor, also multi-drug resistant tuberculosis, extended drug resistant tuberculosis, also second line and third line antibiotic treatment, tuberculosis, urinary tract infections, no trimethoprim, nitrofurantoin, cephalexin, cellulitis, macrolides, and also amoxicillin. Also, gastroenteritis, basically self-limiting. Remember, C. difficile infection with metronidazole and vancomycin, Helicobacter pylori. There's also metronidazole and clarithromycin, and also proton pump inhibitors. And sexually transmitted disease. So there's a lot of them: gonorrhea, chlamydia. But basically, you could go through them all to be aware how to treat them. Basically, mostly are um, doxycycline um and metronidazole. So if you come to fungal infections, so basically most superficial fungal infections of the skin are caused by the dermatophytes. So basically fungus that need keratin, dead skin to live. And basically it's treated with local imidazoles like clotrimazole, meconazole, ketoconazole, oral oral triazoles like fluconazole, itraconazole, fusaconazole, and also local terpenophin like lamisol. There's also Candida or yeast, as we said. Fungus usually is more common. Systemic fungal infections are more common in patients with immunocompromised. So basically, it's also a or resistant organisms, or where there's a failure of topical treatments, and it's usually used fluconazole, itraconazole. Uh, Also, aspergillosis, which is more common in patients with severe immunocompromised patients with COPD or tuberculosis, and they are usually treated with proconazole, itraconazole, um, amphotericin, prosaconazole, and so on. And if you look at the targets for where antifungals target in the fungus, it's basically the ergosterol which is present in the cell wall of the fungus, polyenes like amphotericin and statin, azoles, both the triazoles and the imidazoles, terpenophin and amorolfin. DNA targets include medicines which target DNA include flucytosine and griseovalvin, and cell wall include the echinocandins like all antifungals which end with the mecafungin, caspofungin, and so on. So if you look at some side effects of antifungals, pregnancy, all these antifungals are contraindicated or taken with with more monitoring. Griseofulvin, ketoconazole, voriconazole, posaconazole, flucytosine, amphotericin, distatin, and terbinafine are usually given in pregnancy. Hypersensitivity with amphotericin, but also all antifungals could cause hypersensitivity reactions. More common with amphotericin because of the risk of anaphylaxis. Common side effects include GI, headache, rash, hepatotoxicity, and hepatotoxicity. So basically, triazoles, amphotericin, and ketoconazole as well, and the mecafungin. Other side effects include their enzyme inhibitors. So remember, a lot of drug interactions. QT interval prolongators, so they prolong the QT interval. Also remember interaction with the statins, warfarin, heart failure with itraconazole, hypokalemia with amphotericin, dizziness, phototoxicity with voriconazole. So remember, also the over-the-counter meconazole with the taurine. Griseofulvin also causes bone marrow. So remember neutropenia or anemia and so on. If we look at the protozoal infection malaria, treatment is for It's Briamet, quinine, and Malarone. And also remember, do not use any medicine which was previously used for prophylaxis because of resistance. So if you use, for example, Malarone for prophylaxis, do not use it to treat malaria. So for prophylaxis, remember epilepsy, chloroquine, and mefloquine are contraindicated with patients with epilepsy. Also use nuts with permethrin. Remember to apply DEET after applying sun lotion. So all these are basically common points for prophylaxis, 1 or 2 days for mild doxycycline, and for the duration of your stay, and 1 week after leaving. Also for 4 weeks for doxycycline. Rest of the medicines 1 week before travel, 4 weeks after leaving. Mefloquine, it's got psychiatric reactions, so to make sure the patient has do not experience any psychiatric reaction, so you start 2 or 3 weeks before travel. So also when patients return from a malarious area, if there's fever within 3 months or 1 year, um, check INR. When the patient starts treatment, especially before starting treatment, and then 1 or 2 weeks before travel, so that you make sure it's within the range. Also remember, most antimalarials cause ventricular arrhythmia, QT interval prolongation. Also remember interaction with HIV proteases, dizziness, psychiatric reactions, GI, headache, rash, and as we said, QT interval. So malaria is basically caused by the protozoa, but it's the female Anopheles mosquito is the vector, which basically transfers the parasite to the blood. So it travels to the liver cells. Then when it matures, the schizons are um, secreted in the bloodstream where they infect the red blood cells. Red blood cells rupture, causing more infection. Um, so remember, symptoms of malaria are basically severe anemia and myalgia. So it's problem reduced ability of red blood cells to transfer oxygen, and most the malaria parasite include the falciparum. Um, I meant P. I meant Plasmodium falciparum, Plasmodium vivax, Knowlesi, and Malariae. If we go on, the other important infection is HIV. This is a massive topic, but remember, HIV targets CD4 cells, basically cells which express the CD4 cells include the T helper cells, and it's diagnosed by the ELISA test. HIV-1, HIV-2, HIV-1 is more common in the UK. There's no cure for HIV. Post exposure prophylaxis or pre exposure prophylaxis is basically, I think it's licensed. The Truvada is licensed for the post uh, exposure prophylaxis by the FDA. Um, so seroconversion, when a person gets HIV, they might experience symptoms of fever, myalgia, lymph lymphadenopathy. Also remember infusion, um, reverse transcriptase. Basically, the remember the HIV virus is RNA. So to get into the DNA structure, they need the enzyme reverse transcriptase, then integrase, then protease. So this is basically a textbook basically revision. And AIDS is defined as when T helper cells go below 200 cells per mil. It's There are many opportunistic infections like tuberculosis, fungal infection like aspergillosis, and the viral load is said to be non-detectable basically when the HIV is controlled and you can't detect the virus in the blood. And it's also thought that patients do not basically infect other people when the viral load is less than 50 copies per mil. The treatments include the highly active antiretroviral drugs. Basically, two nucleoside reverse transcriptase inhibitors are used, like zidofin, and one non-nucleoside reverse transcriptase inhibitor, like evaporins, um, or one protease inhibitors. Basically, this is very complex. It's mostly used by specialists. There's also the integrase inhibitors like tegravir. They all contain the tegravir. Infusion inhibitors like invuvertide, the the pharmacokinetic inhibitor copicistat. So basically, copicistat does not have any antiviral characteristic, but basically it boosts other um, anti-HIV drugs. Basically, remember this combination. A brand name is the Truvada, which we said is zidovudine with amitriptyline, Atripla, which I think tenofovir with zidovudine, amitriptyline, Caletra, I think, is two protease inhibitors. So it's very important to know the brand names. In an exam situation, you might be asked, what is Truvada? So remember, there's also resistance increasing in HIV against HIV drugs. So patients, the virus is developing more resistant to anti-HIV drugs. Um, there's a lot of drug interactions between HIV treatments, the antiretrovirals, and other drugs because remember, protease inhibitors inhibit the cytochrome P450 enzymes and increase other drugs. There's also other pharmacodynamic interaction. Side effects include insulin resistance or lipodystrophy, psychiatric reactions or suicide ideation, GI hypersensitivity, hepatotoxicity, rash, and also remember patients, HIV patients, not to take double dose if they miss their dose. There's also renal failure as well.